Hello, everyone. My name is Arya Javidan, and I'm the project manager for the National Consortium of Telehealth Resource Centers. Welcome to the latest presentation in the NCTRC webinar series. Today's session is on priority setting in digital health, and it is hosted by the Pacific Basin Telehealth Resource Center. These webinars are designed to provide timely information and demonstrations to support and guide the development of your telehealth programs. Just to provide a little bit of background on the consortium, located throughout the country, there are 12 regional telehealth resource centers and 2 national, one focused on telehealth policy and the other on telehealth technology. Each serve as focal points for advancing the effective use of telehealth and supporting access to telehealth services in rural and underserved communities. Just a few housekeeping tips before we get started. Your audio has been muted for today's webinar. Please use the Q&A function of the Zoom platform to ask questions. Questions will be answered at the end of the presentation. Please only use the chat for communication issues with technology or communication access issues. Please refrain using chat to ask questions or make comments. Please also note that closed captioning is available, and that is located at the bottom of your screen. Today's webinar is also being recorded, and you will be able to access today's and past webinars on the NCTRC YouTube channel and the NCTRC website at telehealthresourcecenter.org. With that, I will pass it over to Christina Higa, co-director of the Pacific Basin Telehealth Resource Center.
Thank you, Aria. And aloha, good morning, everyone. I'm Christina Higa, and I'm the director of the Pacific Basin Telehealth Resource Center. It is my pleasure to introduce our speaker today and my colleague, Dr. Victoria Fan. Victoria is a distinguished health economist, data scientist, and policy advisor who most recently served as a senior fellow at the Center for Global Development, a nonprofit think tank in Washington, D.C. And she's also an associate professor at the University of Hawaii at Manoa. She earned her Bachelor's of Science in Mechanical Engineering from MIT and her Master's of Science and doctorate degree in Global Health and Population from Harvard University. She has made many contributions to the field in global health and more recently in digital health, and has over 4,000 citations in academic literature. In her talk today, Dr. Fan will present her work with the Center for Global Development and also with World Health Organization on setting priorities for digital health. Thank you for joining us today, Dr. Fan. I'll turn it over to you.
Well, thank you, Dr. Higa, and thank you, Arya, for this invitation. It's great to meet you all and share just a little bit about the work that we've been doing, that I've been doing in collaboration with my colleagues at WHO, but mostly actually with the World Bank. And so I'm just about to share my screen here, if I can get it to work. Okay. Hope you can see my screen. Okay, so I should just caveat that I'm a health economist by training. I'm not a technologist or a healthcare provider like you all, who really do the heavy lifting of delivering patient care. But as a health economist, one of the lenses that I take and that our field takes asks questions about efficiency and also effectiveness, and something that we call cost effectiveness. And so sort of this dismal science of economics is often asking, with a fixed budget or a budget constraint, there's always limited resources. How can I maximize the impact or the health impact with that budget constraint that I have? And so this notion of priority setting can be applied to any field, whether it's your own life, but how you prioritize your time or prioritize a limited resource. But in today's case, we're going to be talking about how do we prioritize within this digital health space. But this is work that I'm doing with colleagues at the World Bank, head of digital health named Marylise Gorgons, as well as Alex Fisher. And I should just also mention that we presented a version of this slide deck back in April at the G20 meeting in Brazil. Okay, so let's see if I can move my slides. So what is this problem of priority setting? Well, as we all know, countries have so many challenges and so many possibilities. We've got, different tools, different interventions. But in order to make a decision, we have to know what are all the possible choices I can make And then I need to proceed to weigh the different options that I have and then make the best decision. I should also say that I'm framing this from a country's perspective, but it could be, you know, the perspective of a hospital or anyone who has a budget, basically. And if we were to translate this into the language of health economics, we would say that we first need to identify our interventions. Like, what are all the possible choices that I can do? Now, of course, in practice, this may not be a realistic choice because hospitals are already providing a set of interventions already. And so switching the sort of set of interventions may only be at the margin, right? You could maybe adding 1 or 2 new interventions as opposed to changing the entire portfolio. But in any case, you want to know sort of what are my choices here that I'm examining. And then within those choices, you know, there could be different ways in which you categorize them, like whether it's, you know, investing in an EMR versus investing in a telehealth platform versus doing something with mobile health. These are all different types of interventions within digital health, and how do we categorize and classify them? And then finally, this prioritization exercise or this economic analysis of how do we think through what are the returns on investment if I choose one intervention or a portfolio of interventions, and what's the potential impact for my practice or for my country, depending on what I invest in. Okay, so that's the sort of framing of the question here. And you guys are all, it's like preaching to the choir. I don't need to tell you why we need to invest in digital now. But again, just to repeat, I think some obvious points here. I think especially during the pandemic, you know, we, the public saw more than ever the value of public health data and the deficiencies in digital health systems, whether it was, you know, a locality or city and county, or state, or even countries themselves, face challenges in reporting the basic COVID data. And yet, although we've seen really massive investments in health, and particularly in the United States, where so much money is spent on health, you could argue that the data systems for health, you know, may be something lacking there in terms of our infrastructure. And certainly at the global level, despite massive investments in mostly infectious diseases, we haven't seen significant advances in our data systems for health. And this is just one example of the consequences when we don't see these advancements. There's this phenomenon in global health that we call fragmentation or e-chaos. I think this is also likely happening domestically in the US as well. But just as an example, in one African country, there was a story from a colleague of mine working in this country that there were 70 fragmented digital health systems, variety of platforms that were all duplicative and were not connected to each other, and all funded by different foreign assistance channels. And so the argument was that this sort of result of more than 70 fragmented digital health systems was really more sort of e-chaos, as my friend called it, and was quite wasteful, duplicative. Okay, so what I want to share with you today are sort of two areas for us to think about in terms of priority setting. And I want to draw from the case, or sort of this body of work called the Disease Control Priorities Project, which use this priority setting view of the world to make an investment case for investing in what was called a highly cost-effective, a package of highly cost-effective interventions. And then I'll talk a little bit about some of the resource tracking platforms that have been used to try to track the investments in different health areas. Okay, so first on prioritization. So my work on digital health, you know, of course, a lot of it was during the pandemic when I was running a 24/7 call center for suicide prevention and isolation quarantine. But one of the research studies that I did after the pandemic was looking at the cost effectiveness or the sort of economic benefits of investing in surveillance systems for pandemic preparedness. And as part of that review, we found this report also produced by the World Bank which attempted to identify existing, let's call them interventions, digital interventions for surveillance, and the studies which found whether they were effective or not. So positive meaning there was a significant effect, right? And interestingly, many of the surveillance technologies and surveillance interventions all had, not surprisingly, a digital health aspect to it. So we had active case surveillance, contact tracing, digital or automatic contact tracing, and so on and so forth, health information systems. And so this list helped us to make the case that we really need almost a best buys list for investing in surveillance. You know, policymakers need to think through how they're going to invest in surveillance, and to do that, they need sort of a top 10 list of things that they should think about as or to invest in as they ramp up their surveillance systems. And sort of this approach of prioritization, you know, as I mentioned, came about from the Disease Control Priorities Project. And just a quick crash course here in health economics, there's something called the cost effectiveness ratio, the CER, okay? And so what this means is you're looking at a metric that's about, that refers to the dollars per year of life saved, dollars per year of life saved. And so things that are cheaper per year of life saved is a better deal. It's like a best buy, right? So if you're going to go, let's say shopping, so to speak, you're going to go shopping for interventions, you're the policymaker, you have your basket, you're trying to decide what is the basket of interventions I want to invest in. You might want to invest in things which are more cost effective, which also means things that have a lower cost effectiveness ratio. So basically it's sort of a cheaper, sort of the smaller the cost effectiveness ratio, the more cost effective it is. Okay, so that's just sort of the basic terminology there. And I also just want to refer to other additional resources that might be of interest to you. There's something called the Global Health Cost Consortium. And this was an initiative that was looking at trying to understand just the cost aspect, sort of the dollar side of many of these programs on TB and HIV, which is a big focus of international foreign aid for health. And then there's the part about effectiveness. Does it save lives? Does it prolong life and prevent mortality and morbidity? And there's an initiative called the International Initiative for Impact Evaluation, 3IE, and they've got, again, a huge amount of information and studies that have evaluated rigorously, or what they call impact evaluation, whether an intervention, quote unquote, saves lives. Now, this, I think, in the field of medicine is kind of part sort of well accepted sort of research. Like we have clinical trials that tells us if something is effective or not. At least that's in the case of our drug. And in the case of this field of global health and development, sort of international development more broadly, we're not dealing with drugs or we're not dealing with pills, right? We're often dealing with programs or sort of something broader than just a pill. And so sort of with this sort of frame of mind that we should be able to evaluate the effectiveness rigorously of programs has grown in popularity in this space. Okay, so more background on this way of thinking of the world. This Disease Control Priorities Project actually began in 1993. The World Bank released this report, the World Development Report. It's an annual report they release annually every year. And at the time, I put a picture here of Larry Summers. He was at the time the chief economist of the World Bank, and he led this report. And it was the first time the World Bank produced a report on health. Prior to that, the World Bank's World Development Reports were primarily on poverty alleviation and accelerating economic growth. And so this was, I think, a paradigm shift that development should and could be about investing in health. What a concept. And here's a picture of Dean Jameson, who was the lead sort of genius who thought of this concept about how do I come up with a list of my 100 most cost-effective interventions. The story goes that Larry asked Dean, tell me the list of the most, if I was a minister of health, I had only fixed budget, what are the 100 most cost-effective things that I would spend on in my country? And after reading this, this report came out in '93, and incidentally, a fellow named Bill Gates read this report, was so inspired by this vision of cost effectiveness. I guess only a technologist can be inspired by cost effectiveness. As he was getting his new foundation, the Gates Foundation, established, he chose to prioritize vaccines as one of those interventions, because vaccines came out as one of the top as being most highly cost effective. And as a result, Bill Gates invested in the second edition of the Disease Control Priorities Project, which came out in 2006, as well as the third edition, which came out around 2018 or so. And as you can see, each successive version was longer and longer. And as we speak right now, the fourth edition is being led by the University of Bergen by a professor there named Ulla Norheim. Okay, so this Disease Control Priorities Project really emphasized interventions, things that we just saw earlier, like bed nets or spraying households to prevent against malaria, or TB vaccines, condom distribution, TB chemotherapy. These are very specific interventions. And I should also mention that everything here, like for example, malaria bed nets, which is say $10, for just $10, you can buy a bed net that saves a year of life, is very cost effective, but also ORT, that's oral rehydration therapy. That's a mixture of sugar and salt that people drink when they have diarrhea. And that costs about $1,000 per year of life saved, because most people who get diarrhea aren't going to be dying. And so you need a lot of cases of diarrhea. Anyway, the point is, all of these interventions are considered highly cost effective. $1,000 per year of life saved is a really good deal. I think in the United States, we spend closer to like $1 million per year of life saved. Okay, so I should just emphasize that the Disease Control Priorities Project emphasized this notion of intervention, something that you can sort of almost take a slice and say, this one piece, this drug, this intervention saves lives. But of course, any intervention requires a platform or a system in which those interventions are delivered, whether it's primary care, whether it's a hospital. And so there's this constant tension within the Disease Control Priorities Project of sort of the intervention, and then the human resources, the digital infrastructure, all of these, the financing, all the systems part that helps to deliver that particular intervention. I should just mention that this approach has been applied not only to health, but in other areas. So more recently, it's been applied in education. So this was a paper published in 2020 that attempted to do something similar, where they ranked 150 interventions in education, and they ranked the interventions by this new metric called learning adjusted years of schooling, and came up with the set of interventions in education which are the most effective, right, in sort of getting the most amount of learning for each year of school that you get. And this has also been applied, at least in theory, to the field of climate change, thinking through which intervention is the most effective given some abatement cost. So this is euros or dollars per ton of carbon-2 emissions, and a variety of interventions that might be available. This was done years ago, and I think still just more theoretical and not necessarily with evidence, but more from a back of the envelope perspective, as say a businessman or a policymaker might think through rough orders of magnitude about how they should be investing in climate change adaptation and mitigation. Okay, so that's sort of the basic approach to prioritization. Now, how do we apply this to digital health? Okay, so I've learned just in the past few months that actually the WHO has an interesting classification of digital interventions, services, and applications. And I think these slides will be shared with everyone afterward. And you can see from this list here to the left, this is a snapshot from the WHO's classification. They've got things like digital health interventions for persons, digital health interventions for healthcare providers, digital health interventions for data services, digital health interventions for health management and support personnel. And it goes into very minute detail. Each one of these rows is a theoretically different intervention, so to speak. I think this is a fairly recent innovation that came out by the WHO. There's another listing that came out by the International Initiative for Impact Evaluation, 3IE, the organization that I just mentioned to you, and they've also come up with their own classification of digital health interventions as well. And as for thinking through how to evaluate these interventions for their sort of cost benefit or cost effectiveness, there are these two studies that I'm aware of, something called the ICT Works Toolkit, as well as the World Bank, have started to think through this framework for the economic evaluation of these different kinds of interventions, but it's a new space. It's a really new space. So again, we're all FOMO, fear of missing out. So we really can't not talk about ChatGPT and AI. And as we all know, there's incredibly rapid advancements that are happening in artificial intelligence, not to mention their enormous energy requirements. But it's still not so obvious, I think, to policymakers or to hospital leaders or healthcare leaders how to best effectively use AI. Every day, every month, there's constantly new articles that are coming out that are talking about we need to think through how we're going to be investing in this. So this just came out in March by Cooper Smith that made the argument that we don't even have good benchmarks for AI applications in global health, and that we need to start thinking through some benchmark methods as we start examining all of these new AI applications. Again, The Economist also in March came out saying there's no standards for AI use, no clear accounting of the risks, no consensus about how to measure the performance, i.e. the benefits or the effectiveness of all these applications in clinical settings. Goldman Sachs just last month said, Gen AI, too much spend, too little benefit. So again, we're really in this very sort of growing space that's asking these questions about priority setting and value for money of investing in AI. Okay, well, there's actually a lot of just to zoom out just a bit, digital health arguably fits within a broader set of investments in the health sector. And in the health sector, at least from this global international perspective, we often talk about things as health benefit packages. Now in the US, we might think of this as, what does my insurance cover? Does it cover all the benefits that I need, right? Or what does Medicare or Medicaid cover? And we call that the health benefit package. Obamacare had some essential health benefits and so on and so forth. And so how we design the health benefit package, of course, has to incorporate not just the intervention, right? Not just like the 100 or thousands of interventions that will be possibly covered by our insurance plan, for example, but it's also about the process and the governance and the capacity for how you design these benefit packages. So this report, this book, What's In, What's Out, Designing Benefits for Universal Health Coverage, was written by one of my colleagues and mentors, Amanda Glassman. So it was a really excellent reference for those of you interested in thinking through these broader questions of like how do we design what's covered and what's not. And even today, we're constantly seeing news of like, should we be covering this newest drug? Should we cover Alzheimer's drug, this new Alzheimer's drug? Should we cover this very expensive cancer drug? And what are the consequences of that? And so this broader perspective of health benefit packages is useful because it's not just about picking the intervention, but it's about the governance and the institutions that help us to make the right decisions as we design this package. Okay, so let's zoom in just a bit to think through how are we going to measure the benefits of digital health interventions. And again, this is where I would love to have a conversation with all of you. You're the experts in this space. There are hundreds and thousands maybe of digital health interventions, so many different diseases, technologies, populations, and generally they're aimed to improve health outcomes for the patients, or they're intended to have some kind of efficiency outcome for our health system. Now, you could argue that some of these pilots are siloed and it's kind of hard to evaluate them, especially when it's so fragmented. The measures, sort of the indicators of costs or benefits, they kind of, it's a motley crew. Every intervention might have its own set of cost measures or performance measures. And as this is a slide from my colleague Alex Fisher. He was arguing that many of these digital health interventions have secondary benefits that will not be easily captured in these formal evaluations, whether they're benefits to the health system or benefits to users or the savings in time, or maybe improvements in quality, improvements in data itself. Very hard to measure the value of improved data, and potentially other cross-sectoral benefits. And so this notion of digital health having many dimensions of benefit makes it not so easily adapted to our very narrow measure of cost effectiveness that we were using before, which was how many more years of life, or how many lives can I save with my intervention. And I think that that is probably the crux of the issue of why it hasn't been done already. It's a really tough problem. And so I think there's a need for a whole agenda to think through these metrics about how we can define what is the value of digital health interventions, and then from there make systematic comparisons across multiple interventions, because I can compare intervention A to intervention B, but they've got so many different dimensions of benefit. How do I make an apples to apples comparison? So as I mentioned, in health economics, our most common metric that we use is something called the disease, the DALY, the disability adjusted life year, or the quality adjusted life year. And again, this is a standard measure used in most cost effectiveness analysis. But like I said, if the DALY or the quality is not fit for purpose for measuring the benefit of a digital health intervention, we need a better metric. And what should that metric be? I don't know. This is I think area where we're raising the question, but we don't know what the metric is. Or maybe someone actually has already done this and can just point me to the study, and that would be great, because then we don't have to come up with a new measure ourselves. So my colleague Alex Fisher has proposed some new metrics here. He's proposing something called a digital DALY, measured along a set of predefined criteria or a set of benefits. He's also called something called a system health adjusted labor year, a SHALI, estimating evidence of some enhanced efficiencies. And then there's another option if we decide that we don't like cost effectiveness at all, that our measure of effect is too narrow. We could also just shift gears and just go to cost benefit, which benefit could be all encompassing of all kinds of benefits. But the challenge with this is it has to be monetized, and that's also very challenging. Okay, so if you're feeling like I haven't told you the answer, that's correct. I've just raised the question and would love to hear from you about what you think the right metric can or should be, or how we could go about to think through what this metric should be. Okay, so I want to shift gears now to talk about resource tracking and coordination. The reason being that I think oftentimes when we in the digital health space, or any field really, we're trying to make the case for investment. We want to show, hey, here's the value that we get in this intervention, and oh, by the way, this is how much we're currently spending on this, right? And I think the second question is about resource tracking, like how much are we currently spending on digital health? Again, it seems like a simple question, but actually turns out to be quite challenging to figure out. And again, from an international perspective, how do we track the resources that we're spending on health systems, around the world in many different countries? And we have something called the National Health Accounts, which tracks, all health spending in a country. There's also things called public expenditure reviews, which look at government expenditures, government contracts, to figure out, hey, what are you government spending on? And if you're again, many of you are coming from a hospital or healthcare provider, so it would be like looking at your accounts and being like, hey, what am I spending on and how much of that is going to a particular area. So this expenditure tracking has grown in popularity, I think, in areas where the disease focus is popular, like, or it's become a major priority. Like in the case of international health and global health, HIV was sort of a big focal area. And so there was a lot of resources spent on tracking resources for HIV specifically. And in the case of digital health, I think, we can't, there's no global number that I can tell you that, hey, this is how much we're spending globally on digital health, or even in the United States, how much are we spending in digital health? I couldn't give you that answer. And it just goes to show that if we're to call ourselves a community, as digital health community, if we want to make that investment case, we still need these two components of making that value for money argument, as well as being able to say, hey, here's how much we're currently spending and here's how much more we need. There's another specific tool, again, in my foreign aid field that tracks donor projects and things like that, but it doesn't actually track digital health. Again, despite the importance and growing demand by countries, remarkably, there's a mismatch between the tools that we have for tracking expenditure and what we sort of really need. Okay, I'm going to skip this slide here. So I just want to summarize my recommendations that I made to the G20, that absolutely we need to identify and classify these interventions, but it's really just the first step before we can actually proceed to this prioritization step. And all of this is all part of making the case and building this package of interventions. We clearly need new metrics and tools to estimate or demonstrate the value and benefits of these interventions in digital health. And we also need to improve our resource tracking for making this investment case. And there's likely to be existing tools that we can that are already tracking expenditures that maybe could be adapted for tracking digital health. But that really requires leadership and stewardship. And I'm gonna, this last point about coordination platforms is more in the case of international donors. This is more from the foreign aid perspective. We've got many payers. I guess in the US case, it would be sort of similar, where you've got many different healthcare payers, whether it's Medicare, Medicaid. In the case of global health, we're talking about a country receiving funding from many different country donors. And that leads to fragmentation, duplication, and really difficult. It makes it really difficult to both coordinate and channel those resources to a shared investment plan. And you could maybe make the case potentially that coordination and fragmentation is possibly also an issue for the US as well. So I want to just stop here and welcome your comments and questions, and thank you for your attention.
Thank you so much, Dr. Fan. I feel like I needed one more cup of coffee to stay on you, but I feel smarter somehow. That was a lot of information, and I really appreciated the way you presented it. Not all of us have economics background or health economics background, but this is so important. I mean, when you think about digital health and the investments that are being made without this kind of study and looking at it. I mean, the fact that you said we can't say right now as a country how much is being invested in this area, it is a statement to say we really need to look at what are these metrics and how do we develop it. And for those of us that work in telehealth, that's the same question, that we have a very difficult time looking at when we look at cost and benefit, because is it cost to the system? Is it income to the system, to the individual, to the patient, to the provider in terms of time, money, travel time, health outcomes, benefits, right? So it's very complicated. It's very complicated, including when you say benefits on like health outcomes. Let's just say we have a telehealth intervention or chronic disease management. That's over a long period of time before you can also see the outcomes to say that that's a benefit. So I think that you just gave us a slightly different angle of how to look at this measurement. And then also how to prioritize. Where do we need to invest in? What makes sense? For us, there are two questions in the chat, but I just wanted to say, for the PBTRC, we work with Pacific Island countries. So at the country level, I think this
Okay.
is a very important discussion point, and I would recommend it to be presented to the Pacific Island Health Officers Association, that includes the ministers and directors of health, because they have a lot of funding and donors, and so they could track digital health, at least investments from donor countries and then their own investments. But I do like the way that you took the country level of prioritizing and helped to put it into the perspective of individual, health centers, put it in like this, even in our own lives, in what we do to invest, where do we invest, where are the benefits, makes a lot of sense to think of it this way, and we often don't. I turned to the Q&A. There were two. One was speaking about the CER, the cost effectiveness ratios for devices such as watches and health monitors. And then I'll just give you two, and then you can answer, whatever order. The second one, I'm not sure, Dr. Fan, if you can see the Q&As.
Yep.
It's pharmacy benefit managers must be doing such analyses on ongoing basis. Do you know the methodologies they use? Are there any studies where they have shared data? Do you think their approach may be saving someone, right? Again, saving whom, right? But runs counter to the best interest of patients? Please comment. And I'm just going to add the last one, and then you can answer in whatever order is suitable for you. The last question that came in is, how do we compare low-tech investments, such as for training people, with so-called digital health?
Great. Thank you for these questions, and I really appreciate your synthesis of my jumbled thoughts here. I think the question from Dan Smith, as well as the other question about comparison of low-tech investments, I think is a really important question. I think my whole message is we need to know what the CERs of these different interventions are. If we were to go and pull out that WHO list of interventions, you being the experts in digital health would be maybe a fun study to do, to say, hey, from my own intuition, here are the set of interventions that I think give you the best value for money, right? And of course, value for money may not be your only criteria, or cost effectiveness might not be your only criteria. And it shouldn't be, actually, right? Because as you design a benefit package, cost effectiveness is not and should not be the only criteria that you use. But you might have some intuition just from your years of working in this field of, a new hospital, or maybe an older, depending on where that particular healthcare facility is, or maybe a country, or even state, depending on which state entity you're talking with. Like, given where they are, here are the set of things, here are the set of interventions that they should be thinking about. And, instead of having some highly paid consultant to give this advice, it would be nice if it was a so-called unbiased research study that we could actually just have that menu or that ranking. So that earlier list that I showed for global health let me see if I can pull up that list again, let's see if I can pull up this list. This list here as an example, I would love if we had this for digital health, right? Like if I only had a fixed budget, how should I be thinking through, all the hundreds of things that the WHO has listed, right? Because I'm sure constantly policymakers are like, hey, there's this new app, let's do this app. Oh no, we've had this other, option, let's do that, right? So how does that prioritization, actually happen? And I think this other question about low tech investments, I think is really, point well taken, is that, you've got a fixed budget. You could be investing it in digital health, and we're just talking about allocating within the digital health bucket. but it's potentially not just with digital health, it could be outside of digital health. Should you be investing in all of these other health interventions? So in the ideal case, we would have everything all listed together and we can make a comparison across everything. And people are even saying we should do this, comparing health to education. Should we do roads or should we do health, right? I mean, the sort of the budget that you're looking at and the decision space that you're looking at really depends on who you are as sort of the quote unquote policymaker or the decision maker. So there's another question here from Lonnie McKenna about which policymaking bodies have these questions and perspectives being brought into. I mean, I would argue, I think that's a great question to ask. And, to be fair, sometimes this perspective seems almost too theoretical, right? But I think in practice, it is being done, certainly from, the ministry. Say in the US, we don't have ministries, we have departments, right? So we have like the Department of Treasury, right? Or in the case of the Pacific Islands, you might have a Ministry of Finance which is making decisions about, hey, here's how much the budget for health, say the health ministry is going to be. And then similarly, the Minister of Health might then proceed to make decisions about, okay, I'm going to take that budget, certain items I have to continue based on, previous year. But then is there a new incremental budget that I can work with that I have can make that decision space? So there's sort of two approaches. Is like imagining you had this budget and sort of changing the entire budget, right? Of course, that's often not realistic because you've already paid for certain things, you're already doing certain things from the previous year, as opposed to adding an incremental intervention given a new additional budget. Like let's say Minister of Finance gives to Minister of Health a 5% increase. What can you do with that 5%, for example? And I think in the case of a healthcare provider, you're often, presented with an annual budget, and you know how much you can spend based on previous year's services, but you might have a little wiggle room that you can work with to potentially expand or do something new. I think oftentimes we're looking at that incremental picture. There's another question about pharmacy benefit managers and sort of, their own analyses and decision making. I think, point well taken that, depending on who you are, meaning like, are you a CEO of your own company, or are you, say, a Secretary of Health? Right? You have a different lens to which you're making those decisions. But I think certainly it's this way of thinking of the world, for better or worse. Great, Dr. Higa's back and joined us. I was just saying that this way of thinking about the world using economic evaluation, I think, is quite prevalent, actually. If you're a CEO of a company and you've just raised, I don't know, $1 million for your company, you want to spend your money in a way that will give you the highest return on that investment. And that, in a sense, is a economic way of thinking. It's sort of like a return on investment way of thinking. And absolutely, we live in a capitalist society where, companies are, private sector is doing this as we speak. And so for us, in often the public sector, where we may or may not have such an obvious sort of, well, we certainly have budget constraints, but we may not be making profits, right? I think that is a different sense of how you measure this value. In the sort of the classical economic view of the world is that the market will, take care of things, because if you don't make a profit in your private sector company, you'll go out of business. Now, in the case of many public endeavors, you might not have, if your public intervention is not profitable, that's expected. In fact, not sustainable is the standard of most healthcare, right? But still, you need to make that case for whether it's legislators or Congress or someone to invest or increase the budget, basically. And to do that, you want to be able to show that value. So that's a long-winded way to answer this question about pharmacy benefits managers. Absolutely, anyone who's making profits, I'm sure, is applying this way of thinking. And I think it would be good for us in this field, let's say, on the good side of things, to try to make that case as well. One last thing I will say about the US is that we're probably the last country on the planet to actually negotiate prices of drugs by the government with pharmaceutical companies. So that announcement, I think, a couple of years ago under the current administration to negotiate 10 Medicare drugs, the prices of them, it was, a huge thing for the US, but actually is standard in all high income countries already. So like places like the UK already negotiate drug prices, often using these kinds of arguments of economic evaluation. And so yeah, US is on whole getting a bad deal. On average, we're paying far more for drugs compared to other countries because we don't have this government public bargaining with the private sector. I'll stop here.
Thank you, Dr. Fan. I apologize, my internet connection dropped. So I reconnected, and I'm just gonna ask Arya for some assistance because the questions got refreshed when I reconnected. So I'm seeing two questions now, one regarding the EHR and one regarding the Oregon Health Plan. Arya or Dr. Fan, were there other questions prior to that?
Yeah, no, I've seen now
okay,
some other questions that have popped up into the window here. There's a question about the problem of spending current money on building future capacity. How would you ever be able to tease out the return on the investment? I think this is a great question on timeframes, and it's true that many of the cost effectiveness studies in the health space often have a short time frame of 1 or 2 years, right? Like if you're gonna get vaccinated or take a drug, the impact can be within a relatively short period of time. And again, this is another reason why doing economic evaluations of digital health are much harder, right? The infrastructure cost can be, the sort of capital cost can be much higher. The recurrent cost can also be higher. And there's a sort of a barrier to entry to like installing a major system, right? So there's a lot of reasons why I think doing economic evaluations in digital health can be harder, but that doesn't mean we shouldn't do it, right? Would electronic health record systems be counted into digital health? If so, how? Let me see if I can pop over the link from the WHO, and you can just immediately check the link here. But I'm quite sure that the WHO classifications of health interventions has EHR. So let me just see if I can chat. Did you get hopefully I've answered that in the window directly. There was a question from one of the attendees about the Oregon Health Plan. That's a great example for those of you who were alive then in 1992. There was a innovative, actually Oregon is a great state where there's a lot of innovations in the healthcare system. And in 1992, I think, or maybe 95, they had an interesting exercise where they attempted to rank order interventions based on cost effectiveness and cover interventions purely on cost effectiveness ratio. And it was both controversial because what ended up happening was things which are cost effective but don't save lives, like dental cavities was covered, but things that save lives but can be very expensive were not covered. And I think this is a classic case that's taught now in health economics training, which the bottom line of this is you should not use cost effectiveness only in deciding what's covered, right? Because just because something is cost effective doesn't mean you, one, have the budget to afford it, because particularly in digital health, the capital costs can be quite large. It may have different impacts in terms of equity. It may have, foundation, it's all these sort of health systems, efficiency questions, these broader multi-dimensional aspects may not be fully captured, and definitely not captured in our narrow cost effectiveness measure. So it would be great if someone, brought this digital health community together to really think through what are all the benefits that you experience on a day-to-day basis, and try to sort of summarize and share that as a sort of manual or sort of lessons, and even if it's qualitative, right? And then trying to put a quantity to it, because sort of we're in this era where qualitative stories are good, but if you can put a dollar amount, that's better. Now that's the social norms that we're living in. I don't necessarily agree with it, but oftentimes a dollar number somehow makes it more convincing, apparently. So did I answer
Yes,
any other
I
questions?
I think those are all the answers there, but I did want to say, yes, from the economic evaluation viewpoint, right? It's you're saying we don't only use cost effectiveness as your measure of benefit. And that's because I'm always reminded from the other way around, because a lot of us don't think economics, right? They don't until we get to our administrator of the hospital or something, and they say, I know that's going to increase access to care, or I know that might have better outcomes somehow, but tell me about how this is going to impact our bottom line, right? So it's like us saying, okay, so that point that you said, the qualitative stories, those kinds of quality improvement things are so important. But it is true, if we must, and if we can put a dollar amount to it somehow to figure that out, then I think it does kind of balance out arguments for this thing. So it's a really good blend. Dr. Fan, I think a lot of times those of us who don't have the economics background, we almost just know that it's something that we need to do, but it's so hard to figure out that it's kind of, we leave it on the side. Like when you go to the doctor and they say, you really need better exercise, or you need to handle your stress, right? Okay, yeah, I know that's so critical. That's something I really, really need to do. And then you kind of just leave it because we don't know what to do. And sometimes I feel like that when someone says, okay, that's a good, the equity issue, Christina, is so important. The access to care and all of that, but this doesn't help our bottom line. Tell me how that's going to help. And then I don't know what to do. And so I think that the framework that you provided for us is saying that it's difficult and it's complex, but you can slice it in different ways, and we have to figure out a good framework. And the other thing that helps me is no one figured this out. Like there's no formula that you're going to present and say, this is how it is. So it's an opportunity, I think, that we can work with, health economists, people like you, researchers like you, to figure out what's the best ways to come up with our own situation, if it's at the national level or even at our health center level, to talk about how to evaluate our investments in digital health. And a lot of all of us know the CMS waivers for telehealth are out there. And a lot of feedback that we're getting is some of the large health systems, they do understand the benefits of telehealth, but they still want to understand the total cost of care and all the efficiencies and effectiveness of implementing these things before they invest further. Because if these waivers end, and the reimbursements with those waivers for telehealth ends, then their formula for return on investment doesn't make sense. So it is really a very, very important time. I think across the country, people are trying to analyze how digital health, and I'll say telehealth specifically, was used during the last years during the public health emergency, and trying to understand that to figure out the policy direction that CMS is going to take, with either continuing it on or making modifications. And those policy impacts are not going to be strictly cost, but it will be other, health outcome effectiveness, all that stuff as well. So Yeah, this is really very, very timely. I think for people who are on the call, like reaching out to, it's not easy to find a health economist, I think. I mean, it's not. So, Victoria, I'm not sure. I know we're coming to the end of the talk here, but do you have any kind of recommendations? Like if someone's out there saying, wow, this really opened up my mind of way of thinking, like how do you approach something like this? Because I have you to call, so I can, ask you for advice. And how do we start to even think about looking at this? And the business people in your facilities are doing, I'm sure they're having to do some component to evaluate this kind of thing, but it may not be in the details that we're talking about today. So
Yeah.
to end, I was just wondering if you have any advice and on how do we move forward, Victoria, and getting some assistance. You did put some resources on, but just your
Yeah.
thoughts on that.
That's a great question. I think, you know, so I have two thoughts about it. One is sort of making the case for your organization. You don't need research to do that. You could do your own back of the envelope types of, cost benefit analysis type of thing. And that's what all these consultancy companies are doing. They're not pulling from research. They're just literally drawing numbers on a napkin and then putting it onto a PowerPoint to make that case. But I think I still, I guess I'm still an idealist that having rigorous research makes your case as an advocate more compelling. And so it does make sense for practitioners to partner with researchers who can generate unbiased, so quote unquote unbiased, rigorous evidence that can be used to help you as a practitioner to make that investment case. I think, like I said, this field is, from what I can tell, remarkably undeveloped. Like there's so many studies on cost effectiveness of HIV. That's partly because there's so much money spent on HIV internationally for foreign assistance, which the US has been a major supporter. But like the cost effectiveness of digital interventions, to my surprise, is just very, like there's just very few studies out there. And I was kind of shocked to discover this. It goes to show that there's a need for potential greater collaboration with the digital health community or the telehealth community, or whatever this community is called, with health economists or even epidemiologists who tend to focus only on the effectiveness side, but they don't focus on costs. Health economists will focus both on the effectiveness and the cost side of things. And absolutely, I'm happy to take any questions, and if you want to reach out, by all means, send me an email. I'm always happy to collaborate, to brainstorm if I have time. And no, I'm just super excited to be connected with this community. So thank you, Dr. Heger, for bringing me on today. But I think it would be a really great group project. I know group project often gives us terrors, but I think this would be a great shared agenda potentially for this community to try to raise, like, what is the value for money of telehealth? And hey, with these policies potentially going into sunset, what's at risk? What will the consequences be? What is the cost benefit of these programs, and what's going to be lost by not doing them, the opportunity cost? So
Absolutely. Thank you so much, Dr. Fan. It was very enlightening today and inspiring. I'm going to thank you again and turn it over to Aria for closing.
Thank you, Christina. I'm just going to bring up our closing slides. There we go. Just a reminder that our next webinar will be held on Thursday, August 15th, and that will be hosted by the Telehealth Technology Assessment Center. It will be on connecting closer to home, why broadband and telehealth need each other. Registration information is available on the NCTRC events page. And lastly, we do ask that you take a few short minutes to complete the survey that will pop up at the conclusion of this webinar, as your feedback is very valuable to us. Thank you again to the Pacific Basin Telehealth Resource Center for hosting today's webinar and to Dr. Fan for her presentation today. Have a great day, everyone.